Good morning all. We are going to discuss about the muscular dystrophy. Let us see there is a definition of muscular dystrophy. It is an autosomal dominant disorder. Muscular dystrophies are characterized by progressive skeletal muscle weakness. This weakness of the skeletal muscle, defect in the muscle proteins, and the death of the muscle cells and tissue. It's mainly affected in the muscle cells, its proteins, cells, and the tissue. So, what are the signs and symptoms present in the muscular dystrophy? You can see it in this picture. They can mention the poor balance. There it is a curvature in the lower back that is called lordosis. Then protrude belly. There is projection in the belly, tiptoe, then calf muscle pseudo hypertrophy. There is a tightness of the calf muscle. These are the changes present in the muscular. Causes of the muscular dystrophy. Muscular dystrophy is genetically inherited. However, mutations of dystrophin gene and nutritional deficit are responsible for the disease. It's a genetic disorder. It's affecting the dystrophin. It's a nutritional defect responsible for disease. The main cause of the disease is due to the lack of muscle protein, like the dystrophin and dystrophin associated protein complex is defected in the protein from in the muscle. It's dystrophin and the dystrophin associated the protein complex. Okay, there it is 30 types of muscular dystrophy, but let us see the important most of them affected the types. Let us see one by one. There it is Duchenne muscular dystrophy, Buckus muscular dystrophy, limb-girdle muscular dystrophy, and myotonic muscular dystrophy. These are the common types it's affected the people. But there it is around 30 types of. Look at this picture. You can see it. What are the areas it will be affected? These types. It's mentioned one by one. Yeah. Main area of the muscle weakness, the different types of dystrophy. Yeah, what are the changes present in the muscular dystrophy patient? The shoulder and arm are held back abruptly to when walking. While that is walking, the shoulder and arms is pushed back, and so back there it is form of lordosis. Then anterior curvature of the spine, the weak buttock muscle, hip stiffness, and it's a loss of flexibility, flexion of the hip. So weak buttock muscle, knee may be bent. There's a hyperextension of the knee. It's a general curvature. A thick lower leg muscles is mostly is fat and not strong. The tight heel hard, contracture, and child may walk toes. The belly sticks. How to do that? Is protrude in outward belly muscles. Then thin, weak, tight, especially front part, poor balance, forms of and clumsy if walking. muscles in front of the leg cause foot drop and tiptoe contraction. Weak muscles in front of the leg cause so where it is a foot drop and tiptoe contractions. These are the signs and symptoms. Let us see the patient. We can discuss that one go was and look at this picture. We can mention 1, 2, 3 how they can wake up from the sitting to standing. In the first picture, they shows in a kneeling position. After that, we can place a second picture. It shows the both limbs, lower and upper limb, placed over the ground. After that, one leg is placed over the knee, slowly balanced. After that, another hand placed over the knee, and after that, slowly waken. That is a medical sign that indicates weakness of the proximal muscle. Proximal means major muscles, is namely those of the lower limb. That sign describes patient that has to use hands, arms to walk up the whole body squatting position due to the lack of hip and thigh muscle strength. There is a weakness of the thigh and the hip muscle. See hand push on legs to stand to go aside. See these pictures how they can try to wake up these children. Then diagnosis, how you can diagnose that it is a muscular dystrophy, how we can find out. The serum creatine phosphokinase level is increased. Let us see. Check the blood, serum creatine and phosphokinase level. Then electromyography, so we can find out. Nerve conduction velocity study. Then muscular diagnosis and muscle biopsy. Imaging studies, electrocardiogram, echocardiogram. These are the investigation to find out the condition is positive or negative. Let us see it. Then differential diagnosis. Already we discussed the main types where it is. Okay. Then what are the differential diagnosis to differentiate the types? Then Berger's calf pseudo hypertrophy is mass elevated in CPK, creating phosphokinase. X transmission. Buckles has slowly progression weakness of the muscle. Okay, you can see it on the board. There it is mentioned the types, how they can differentiate diagnosis of the types. Then differential between Duchenne muscle dystrophy and Berger's muscle dystrophy. Already we discussed the 4 types. Most of them commonly affected the conditions. So let us let us see difference between the Duchenne muscular dystrophy and the Berger's dystrophy. Age in Duchenne is early onset, 2 to 5 years. The Berger's type, you can see it is the signs and symptom changes in 8 to 10 years. More common is less common. Most common conditions types in the Duchenne muscular dystrophy is less one is a Berger's dystrophy. Is a progression rapid is slowly. Is do it the progression get it in rapid, but there is a Berger's dystrophy. We will get it the progression is slowly. Then intelligence is subnormal, is normal, but because dystrophy, let us see the intelligence, then IQ, there it is a normal compared to the Duchenne muscular dystrophy. Then cardiomyopathy is common, is rare. Dystrophin level contractures yearly, non-yearly contractures true. Then associated problems is cardiomyopathy and polar blindness. An ambulation, and then there it is a movement till 9 to 11 years. The beyond over that 15 to 20 years. Prognosis severe death by 16 to 20 years. Most of them they can survey their life to 16 to 20 years. Less severe is begin cause to illness death in the fourth of the fifth decades. These are major difference between Duchenne muscular, major difference between the Duchenne muscular dystrophy and Behr's dystrophy. What are the complications? What are the major complications present in the muscular dystrophy? Cardiomyopathy, weakness of the calf muscle, then decreased self-independence and mobility. Decreased in self-independence and mobility. They need the dependent to others, other health workers. They are supported the family also. It will be reduced the mobility. Then lung failure cause of death. Then muscle tightness around the joint. Slowly, it's a later stage. Reduce the range of motion. This weakness of the muscle. The muscles go to atrophy. Tightness. Finally, there it is tightness around the joint structure. Then mental impairment. There it is the difficulties to affect the mental illness of the patient. The physical examination, when we see that patient they have affected in the muscular dystrophy, let us see there is a physical examination. What are the changes in the muscular dystrophy patient? Generally, neck flexor, tensor, quadriceps and tibialis, anterior biceps and triceps muscles are affected more. It's mainly major muscles it will be affected. Neck flexor, tensor, quadriceps, quadriceps and tibialis, anterior biceps and triceps muscles affected more. Deep tendon flexors, reflexes, deep tendon reflexes slowly diminish and ultimately disappear. Then calf muscle enlargement. Calf muscle enlargement, there it is a weakness is there, it is tightness of the calf muscle compared to the normal. There is enlargement at the muscle. Contractures of the iliotibial band, IT band, and hip flexors and heel. Then equinovarus and deformity angle is universal. Equinovarus valgus means an inward deviation of the foot. The equinovarus means outward deviation of the ankle. The asymmetric weakening of the paraspinal muscle leads to the hyposcoliosis, which is tend to further compromises pulmonary and gastrointestinal function. Then treatment. There is no medical cure for this disease. Much can done the treatment complications and improve the quality of life affected the child. There is no treatment to cure this condition, but they can maintain and that condition to prevent the further complication to improve the quality of life affected the children. Cardio decompensation often respond initially well to diagnosing. Cardio decompensation often reopen to initially well done to diagnosing and preservation of good nutritional state important. We want to maintain the vitamins and the minerals and the body conditions to be oriented. Then there is no cure for uniform muscular dystrophy, but due to muscular dystrophy, corticosteroid may slow muscle to destruction. Corticosteroid came to slow muscle destruction. The muscle will wasting or the muscle will proteins will be affected. You can give it the steroids, it will control to do it the processing, it will be slow. In myotonic tonic muscular dystrophy and phenolktoin and procrastinamide and quinine can treat delay to the muscle relaxation. So muscle dystrophy, to get the muscle relaxation, we can give it the medicine to support the muscle relaxation. Gene transplantation research are going. Therapy management, where it is a major role after these conditions in the physiotherapy. Some techniques they can use to maintain, to gain the muscle power, to maintain the balance and the mobility, to maintain to stability. These are the signs and symptoms to control it. Duchenne muscle dystrophy is often divided into three stages: early stage, transitional stage, and later stage. And later stage, the name is called ambulatory. Early stage, weakness of major hip extensors or gluteus maximus muscle, the abductors, gluteus medius. Then adductors become weak. Then angle dorsiflexor become weak. Then abdominal neck flexor, shoulder abductors, the shoulder elevators and depressors are also involved. Neck flexors, shoulder abductors and the shoulder elevators and depressors are really are also involved. In the early stage, we have seen there it is hip, extensor gluteus maximus, abductor gluteus medius, and adductor muscle, and dorsiflexor become weak. Then abdominal neck flexors, shoulder abductors, shoulder elevators, and the depressor. Compensation of the ear is increased and limb lordosis, lumbar lordosis. It's a slowly, it's progression, slowly it's a change to the body posture, increase the lumbar lordosis, is the anterior curvature of the spinal cord, lack of heel strike. There is a difficult to heel strike. They will be start to walk the tiptoe walking. Then increased hip flexors during swim to clear food. Then food may be pronated and averted. Pronated or averted. Then cadence of decrease, where it is a speed, it will be reduced. That's my stage. There it is a second stage. The progressions of muscle listen to early stage with more marked increased weakness in the quadriceps and the ankle elevators. In compensation stage, we support to widen more increased falls, and then knee buckling, quadriceps weakness. So there is a chance to knee buckling, then causes more falls. There will be more chance to fell down falls in the patient. As developed in the muscle like which muscles, it will be affect the tightness, iliotibial band and tensor fasciae reflexors, um, hamstring and the gastrosoleus and posterior tibialis. Functional losses inactivate to elevation against the gravity. Then inability to from floor, rise from floor. Now inability in stair climbing and difficulty from rising of the chair, difficulty to rising the floor, difficulty from rising on the chair. So inability to stair climbing is a difficult one, is a weakness of the lower major muscles. It will be affected. What are the muscles? Already we have discussed the gluteus maximus, medius, adductor and flexors, major muscles of the quadriceps. So it's difficult to raise from floor, climbing and from the chair. Later there it is a third stage, that's its other name is called ambulatory stage. Upper limb weakness becomes more prominent. And let us see. Before that we can see it, there it is a weakness. This stage we will see it, there it is weakness. We can see it very prominently. Elbow extension weaker than the flexion. For more supination is weaker than the pronation. Wrist fingers extension weaker than the flexions. Then scoliosis is seen caused due to the posterior pelvic tilt. Upper limb weakness become more prominent. What are the elbow extension weakness in the flexion? For arm supination weakened in the pronation. Then wrist and fingers extension weakness in the flexors. Scoliosis is seen to cause due to the posterior pelvic tilt. Compensation, leaning for the stability. Leaning for the stability. Contralateral trunk, leaning to compensate the upper extremity function. Using mouth to grab the finger and compensate the upper extremity function. Leaning for stability. Then contralateral trunk, leaning, compensate the upper extremity function. Then using mouth to grab fingers to compensate upper extremity function. The symptom present in the stages, early stage, then secondary stage, then final one, there is an ambulatory stage. Then respiratory involvement, what are the changes present in the respiratory factor? Then respiratory changes. Then respiratory insufficiency, major cause of death in 90% of Duchenne muscular dystrophy patient. Causes of respiratory problem: less inspiration due to muscle weakness and decreased lung expansion. Decreased lungs and the expansion, decreased coughing and the ability. Then restricted chest wall mobility and the impact of the spinal deformity. These are the changes. These are the involvement in the respiratory function. Respiratory insufficiency major cause 90% and the type of Duchenne muscle dystrophy. The cause of respiratory problem: less inspiration due to muscle weakness, decreased lung expansion, decreased puff ability, restricted chest wall mobility, impact the spinal. Cardiac involvement. What are the changes present in the cardiac function? The cardiac muscle is affected by the dystrophic process. The myocardial fibrosis is a muscle is thickness, is a tightness of the muscle may occur primarily involving walls on the left ventricle. The spectrum in abnormalities with cardiac involvement includes AV, atrioventricular block, atrial paralysis, atrial fibrillation. Arrhythmia. Arrhythmia means irregular heartbeat. Conduction defects and reduced ejection fraction. AV block, atrial paralysis, atrial fibrillation, ventricular arrhythmias, conduction defects and reduced ejection fraction. Physiotherapy management, early stage, education of the family, prevention of deformity, maximizing strength and functional capabilities, intervention to maintain ambulance. Physiotherapy management, what we focus to re-educate the patient, education the family. We can discuss about the condition in the family and the patient, the prevention of the deformity, how we can prevent the deformity to that condition, to maintain, to prevent the further complication of the patient. The maximizing strength and functional capability. Now, we can achieve that patient do it the functional capability. We can train to teach them. Then intervention to maintain the ambulation, where we can give it the techniques and the exercises to maintain independently how they can ambulation. Without the support, we can educate them. Then second stage, the transitional stage, the stretching out of the muscle. There is a tightness in the muscle, so we can focus to do it, the stretching, to relax and to prevent the tightness of the muscle. The lower extremities, let us see the muscle. They can tight in the iliotibial band and the tensor fasciolata, hip flexors and hamstring, gastrosoleus and the posterior tibialis. We can focus to do it, the stretching. These muscle, it will be affected in the its loss and tightness of them. So we can focus and do it, the techniques of the stretching to relax the muscle to prevent the tightness. Then upper extremity, elbow flexors for arm pronators and wrist and finger flexors. Passive stretching must be done the best achieved by the standing. In this condition, they can do it the active stretching. We can focus to the passive stretching, do it the best achievement of the standing. Then PNF technique in the PNF technique, we can use hold and relax techniques. Mainly, we can use it the hold and relax technique. It will be helpful to regain the muscle. Then joint mobilization, the patella, the elbow anterior and posterior movements, tibia, femur. Yeah, we can focus to the joint, the patella. There it is a gliding movement. It's a tightness of the knee joint. There is elbow. We can do it the movement, and the anterior and posterior movement. It's a tibia and femur. These are the joint to focus to mobilize the stretch to the condition. Then myofascial release, there it is a tightness to can give it the techniques to release the muscle tension. Then moist heat to increase the comfort and tissue and increases, but excessive heat should be avoided. It is damage to the tissue. So we should give the comfortable, bearable heat to give the patient. We can prevent the excessive heat to avoid the bands of the patient. Then positioning, the prone lying and the wheelchair position should be trained. We can mainly focus to prone lying, the wheelchair positioning, how they can handle the wheelchair, how they can use the wheelchair. We can train the patient to do it perfectly, should be trained the patient. Then final stage, that is the name is called the ambulatory stage. The continuation of the program is a transitional stage. That we can continue what are the program we should continue from the starting. We can do it, continue that one in the early stage and the secondary stage. The final stage we should follow that one. Then long period of rest and immobility are avoided. We can give it the break in the long time. There it is a chance to get the restriction to the joint. So we can give it to avoid the long period of the rest and immobility. Then position and support for the function. Yeah, we can do it the position and support for the function. To do it maintain the position perfectly. Then swimming, the hydrotherapy is helpful. They can do it the movement freely compared to the normal. So we encourage them. Then trick riding, not uphill. The promotion, the orthotic and deformities and the hip, knee, ankle, foot orthosis. And then gait training in a parallel bar. We can give it the training the gait training to the gait in front of the mirror between the parallel bar. The transition from one position to sitting to standing and standing to sitting. We can teach them to how they can do it easily. We can train them. The spinal brace to avoid the correct scoliosis. We can ask the patient, advise the patient to do it the spinal brace to avoid the spinal deformity, the scoliosis and liposis and the things. Okay, major important things we can discuss in this the muscular dystrophy. It's a genetic disorder, so its types majorly it's affected the Duchenne muscular dystrophy and Burkitt's muscular dystrophy and limb-girdle muscular dystrophy. There it is more than 30 types. Majorly it has been affected these three types. And then what are the changes present in the each types, how they can diagnose it, how we will management, how we will give the treatment. These are the things we can see it this condition elaborately. So you go and refer these conditions to elaborate to do it well. Okay, thank you all.
Our